a very good friend and a cornea expert of national and international repute, Dr. Rishi SWARUP from Hyderabad, and he's going to dwell into nuances of how to have successful outcomes in cataract surgery when you are already dealing with corneal disorders. Over to you, Dr. Rishi.
Thank you, Vardhaman, for involving me in this lovely course. I wish we had a little more audience though. But anyway, this is what you expect at, at 8 o'clock in the morning. So when we talk about cataract surgery in corneal disease, it's cataract surgery in the presence of dry eye ocular surface disease, presence of a scar, which may be varying from mild to severe scar, eccentric to central scars, presence of cataract, a compromised endothelium and its implications, irregular corneas, which may be vary from mild to severe irregularity. Some of these irregularities could be from scars or from ectasias also, or post-RK kind of eyes, and then of course eyes that have had some sort of a keratoplasty, either penetrating or lamellar. One of the common conditions that you will come across is conjunctivochalesis, and that will cause a lot of irritation and watering to these patients post-operatively. So, if you notice conjunctivochalesis during your cataract evaluation, it's a good idea to address it intraoperatively, either using a cautery, or you can surgically excise the redundant conjunctiva, so that these patients will not trouble you post-operatively. Otherwise, you'll do a good cataract surgery, but they'll keep complaining of watering and irritation, and everything that you do will go to naught. When you talk about a scar, typically, we describe it as nebula, macular leukoma, but rather than the density of the scar alone, I think the location of the scar that is really important, and the size of the scar, and of course density does play a role. So, if it's a small eccentric scar like in this picture, which is not really affecting your topography or visual axis is clear, it will not hamper your visualization or the visual outcome, then it's, I think, a good idea to just go ahead with your regular phacoemulsification without really modifying too much, and you can just do your routine surgery. If it is a paracentral kind of a scar, then you can do a modified phaco, in which basically you are doing a regular cataract surgery and combining it with some special maneuvers like use of, say, an endoilluminator, or you may use staining of the capsule or other tools to improve your visualization and outcome. If it's a dense scar, then which is going to preclude your visual outcome, then it's a good idea to address the scar with a keratoplasty alongside, which is called a triple procedure. So, this is just an is there a pointer? This is just an example of phacoemulsification in a scar. You can see the moment you put dispersive OVD, suddenly your view improves quite a bit, and that's because the surface becomes more smooth. So, everything becomes a lot more visible. This one, right? Yeah. Endoilluminator, I think, is another tool that every cataract surgeon should have. Routinely the retina specialists use these, but they are available standalone as well. You don't really need to have a retina machine for it, and it's just a small LED light, and you can connect your light pipe to it, and it gives you a very good visualization of structures inside the eye. So, it can be used for all steps of cataract surgery, and also to visualize other things that might happen, like a desmus detachment or a vitreous loss or a capsular tear. All of these can be seen very well, especially in opaque corneas. So, this is just a case example of, I am sorry? No, through the limbus. You can put it inside the eye, or you can even put it on the surface tangentially. Yeah. So, this is just one of the cases which had a chemical injury. We did at that time we were not doing SLET. So, this was a CLET, which is limbal epithelial transplantation, and then the patient ended up with a reasonably okay ocular surface with some peripheral scar and vascularization, and that scar caused significant amount of astigmatism, as you can see in this picture. So, we did go ahead and did a toric IOL in this case. You can see this fairly regular astigmatism, even though there is asymmetry. There is not much of skewing, and that kind of causes a reasonably acceptable outcome when you use a toric IOL, and that is what we used in this case and got a very good result. Compromised endothelium can vary from just guttate changes to frank bullous keratopathy, as you are seeing in this picture. So, if it is just guttate changes with no edema, just doing a careful phacoemulsification with explained prognosis may be good enough, and you tell them that there is a possibility of a keratoplasty later. If there is mild edema, which means there is no clinical edema and the Pachy is less than 650 microns, and you can still go ahead and do a careful phacoemulsification, but tell them about the possibility of keratoplasty. If it is if there is clinical edema and frank bullous changes, etc., then of course you don't have a choice but to go ahead and do a triple procedure, and usually we combine an endothelial keratoplasty with the cataract surgery. Now, when you see in the second scenario, sometimes you don't see any clinical edema, but if you ask the patient a history, they will give you a history of morning blurring of vision. Then in such cases again, it may be an indication that the endothelium is not able to cope, and you will eventually need a keratoplasty. So, this is a post graft eye, but it could be a Fuchs, it could be any other situation with a compromised endothelium. So, principles remain the same. You want to minimize the endothelial damage caused by your maneuvers. So, you want to do soft shell. If it is a graft, you want to make your wound outside the graft, in the bag, slow motion phaco with hyper settings. And in such cases, better to avoid hydrophilic lenses, because if you require an endothelial keratoplasty, hydrophilic acrylics we know can have IOL calcification when it comes in prolonged contact with air. Irregular corneas, the three common indications situations are pterygium, post-RK, ectasia and keratoplasty. I will avoid the post-RK and ectasia because they are going to be covered later. Pterygium is something we see very commonly, and of course post-keratoplasty I will cover. So, when you think about a pterygium, it is a chicken versus egg situation. Should you address the pterygium first, or should you go ahead and do the cataract first and then see if you need to do something about the pterygium, or both together? I think the decision tree depends on the size and activity of the pterygium and whether or not there is pupillary involvement, and if there is distortion of the cornea on topography. So, topography is a very useful tool when you see a pterygium. Even if it is a peripheral pterygium, I think it is a very good idea to do a topo and see if there is any irregular astigmatism being caused by it. If it is, then it is a good idea to address the pterygium first, give a gap of 3 months at least, and then do the cataract surgery, because corneal remodeling can go on for 3 months. If it is not affecting the central cornea so much, you could go ahead and do a regular cataract surgery if it is a non-progressive or atrophic pterygium, and it is completely ignore it. If you are thinking of doing a toric IOL again, please remove the pterygium first and only then give to a toric lens after 3 months, because the corneal shape will keep changing. Of course, if it is a fleshy mass like this, you have to address that first. It may be reasonable to do cataract surgery with pterygium together, but then in such cases no question of doing a toric lens. You must go for a regular monofocal lens, because the spherical because of coupling effect, the K value, the net K value will remain the same. So, it may not matter so much. So, I will just run through this little video to just see if I can. I am not able to. We will skip this video because it is too long. I am going to skip this as well as this. So, one of the things to remember in a post-RK is try to do scleral wounds, especially if the cuts are more than 8. Otherwise, you can end up with this is my first post-RK video. You can see it is an old video, and I was stupid enough to do a clear corneal incision, and you can see I had to put lots of sutures, which ended up looking like this, a very funny kind of suturing. Okay, so cataract surgery and corneal grafts. When you talk about in the situation with grafts, it's either after a graft or you're doing a triple procedure together. So after graft, technique really depends on whatever works well in your hands and is least traumatic to the cornea. So if cataract ECC is good for you, by all means, or SICS, whichever is least traumatic. In fact, many of my post keratoplasty cataracts are small incision cataract surgery, because in my hands that's the least traumatic to the endothelium, especially if the cataract is intumescent, etc. I think, or a hard cataract, you will end up damaging the endothelium with the phaco energy. So this was one such case, had a therapeutic keratoplasty, and soon after the keratoplasty developed a intumescent total cataract, shallow AC going into phacomorphic glaucoma, and so we had to kind of urgently go ahead and do the cataract surgery, even though all the sutures are in. Typically, you would want all the sutures to be out before you do a cataract surgery, but here we didn't really have much of a choice. And as you can see, we've managed to decompress the lens, and the antechamber could be expanded, and we could do a safe small incision cataract surgery in such a situation. When you're doing a phacoemulsification, some important principles to remember: wound location, try to be outside the graft. If it's an eccentric graft, choose a site where you have more peripheral cornea to work with. You want to use as small an incision as possible and do the entry outside the graft as possible. And remember that these wounds ideally should be sutured, because your wound will induce a lot more astigmatism, and you can control that, and they also can tend to leak more often. Again, if it's a penetrating keratoplasty, you want to follow the principles of compromised endothelium, soft shell, in the back phacoemulsification, etc., etc., slow motion, the principles which we talked about earlier. IOLs, it can be challenging to calculate the lens in some of these cases, so use the appropriate tools for it. Toric IOLs can be used if the astigmatism is more regular than irregular. Avoid multifocals and EDOF lenses as much as possible, and again avoid hydrophilic acrylic lenses in case you need to do an endothelial keratoplasty later. Piggyback toric lenses are again a simple, very useful tool for refractive surprises which you might get in these cases. So, this is just one case, phacoemulsification after a DALC. You can see there was some amount of asymmetry, but the patient got a good outcome. This was another case just to highlight a scleral tunnel is a good idea for all grafted eyes. I learned this the hard way in one of the cases. So, this is a patient who had a very high cylinder. We used a custom toric lens and got an excellent outcome. So, this is another patient who had a DALC. You can see very clear graft, toric lens, and patient got beautiful result. Now, this was one case. I just want to show you one video. I am trying to do phacoemulsification after DALC, and you see I felt a give, and at that time I didn't realize what was happening, and I went ahead and tried to do phacoemulsification. You see I am trying to get the cortex, nothing's coming. So, what I have done is I have detached the Duas layer, and now I am going to make a hole in it with my phaco probe. There you go. And that was a disastrous result to a very nicely done DALC. Anyway, we were able to salvage it with the endothelial keratoplasty later. After endothelial keratoplasty, it's pretty much the same as a routine cataract surgery. Just be sure that you don't detach the endothelial graft, and again you have to respect the endothelium. I think I'll skip the triple procedure. So, just one thing about the triple procedure. Typically, in a penetrating keratoplasty triple, you try to do an open sky, but many of the times if the cornea is too opaque, it's a good idea to just do a lamellar keratectomy, just enough to be able to see, as I have done in this case. And once you have finished the phacoemulsification, then you can remove the button and then go ahead and do it as a penetrating keratoplasty triple. So, to conclude, cataract surgery is possible in eyes with compromised corneas, and it's a huge spectrum of conditions. As you can see, I've got so many videos, but obviously time is of the essence. It's important to select your intraocular lens properly and assess the case well. In most cases, closed chamber phacoemulsification is possible, and you can get good outcomes in a majority of these cases. Thank you.
Thank you very much, Dr. Rishi. I think it was a very nice and quite comprehensive in a actually quite short time. I think a couple of pearls that you shared were very important. I think most people would not know that hydrophilic lens should be avoided in these scenarios wherever you expect to do a DSEC in the future, or along with the DSEC surgery because of the opacification of the lens. That was a very nice pearl, and of course all the other pearls that you have shared to make it easy for people to make it clinically, let's say, relevant and give more optimal outcomes to our patients with cataract and corneal disorders. So thank you very much for your excellent deliberations. Thank you.
Thank you.